Hello, today we're going to talk about depression. We'll differentiate between depression, dementia, and delirium, how to screen for depression, and we'll review some treatment strategies for older adults. 75-year-old woman lost her husband of 51 years last year and moved to a town to be closer to her daughter. She has become more forgetful recently. She still drives, cares for her own finances, and cooks. What do you think her memory loss is due to? Do you think it's due to early dementia, depression, delirium, or mild cognitive impairment? It is due to depression. Early dementia, usually patients don't complain of memory loss. They don't know that they don't remember. And with dementia, patients don't have the awareness, and usually families will bring them in and say, there's a problem with mom's memory, and mom will say, oh no, I don't have a problem with that. She probably has depression because of the loss of her husband. Delirium is more fluctuating course, and oftentimes patients are worse in the morning or in the evening and then are better in other times during the day. With mild cognitive impairment, we oftentimes see loss in IADLs, and her instrumental activities of daily living are still intact as she still drives and manages her finances. With dementia, if I do a dementia evaluation, I oftentimes cue the patient when they don't remember the items I ask them to recall. And in many cases, I will give them a visual cue, and I will say, for example, I want you to remember pen, watch, and the color green. And I use those items because then I can cue them with a color, and I usually don't wear green. But patients with dementia will then say after the cueing, they will say, oh, red, because they look at me and see my red sweater today. Patients with depression will say, oh, it was the color green, because if I cue them with one of them was a color, they will remember because they put it into memory, but because of blocking, they cannot recall it. With the watch, I will cue them and say, one of them was a piece of jewelry. And patients with depression will remember the watch. Patients with dementia will not think of the watch because it's usually covered by my sleeve, and they will look at me and say, necklace then. So that's a way of differentiating between depression and dementia. Suicide increases with increasing age. The biggest risk is being an older male, white male in particular. So if you have an older man whom you have to give bad news, then you might want to ask about depression or suicidality. Do you remember Robin Williams? He was given the diagnosis of Parkinson's, and then shortly thereafter he committed suicide. He has had a history of depression, so asking patients like him about suicidality is really critical. It might not have prevented it, but still it's important to ask. So losing loved ones, depression, living alone, and being a male older adult are big risk factors for suicide. Also poor health, poor sleep quality, and using substances. Oftentimes patients self-medicate with alcohol for anxiety or pain medications, etc. And being Caucasian is a risk factor. So antidepressants in younger patients actually have a warning in them that it may increase the risk of suicide. In older adults, that is not the case. Antidepressants across the board reduce the risk of suicide in older adults. So don't be afraid to treat older adults with antidepressants. And this is the study showing the age ranges and the decreased risk of suicidality in older adults over 65 with antidepressant treatment. So in older adults, depression presents oftentimes very different, not so much with sadness or crying, but more so with feeling worthless, helpless, having no energy. The USPSTF recommends that adults be screened for depression, and therefore now the meaningful use criteria include depression screening for older adults, but also the MDS in the nursing home requires the assessment of the PHQ-9. The MDS is the minimum data set that nursing homes have to do on a regular basis on their residents, and the minimum data set includes the PHQ-9 screening test for depression. So depression diagnosis is done with the DSM-5 criteria, but screening can also occur with the 15-item depression scale, a 5-item short version of the depression scale, the PHQ-2, or the PHQ-9. The DSM-5, which came out in 2015, is not significantly different from the DSM-4 in terms of the depression diagnosis. However, the bereavement exception was removed. Previously, patients who had undergone a grief reaction were not recommended to be treated for depression for a while to allow the body to grieve, so to speak. That has been removed because we found no adverse outcomes from treating depression, even shortly after a grief process, if the patient is depressed. The DSM-5 requires 5 symptoms in a 2-week period and at least one either depressed mood or loss of interest or pleasure. Symptoms impair social, occupational, or other functions in the patient's life and are not due to substance abuse or medication side effects or medical conditions. These are the 9 symptoms of depression on the DSM-5 criteria. And this is the geriatric depression scale. I have arranged the answers on the questions on the geriatric depression scale so that the first 10 items are positive if answered with yes, and the last 5 items are positive if they are answered with no. There are 5 items in the middle, number 7 through number 11, that constitute the short version of the depression scale and have been validated. So if a patient is quite depressed and may not be able to complete the whole 15-item scale, then starting with the 5-point scale to at least get a validated result might be a good option if the patient may not complete the whole scale. If 10 are positive, it's considered a positive screen on the 15-item scale. In the 5-item scale, if 2 or more are positive, it's considered to be a positive screen. And this is a study looking at the sensitivity and specificity of the PHQ-2, which consists of, in the past 2 weeks, did you feel down, depressed, or hopeless, or have little interest or pleasure in doing things? This is the PHQ-9. It oftentimes requires more cognitive function because patients have to abstractly think of how often things have happened in the last 2 weeks. And many times profoundly depressed patients cannot complete the PHQ-9 because it is quite complex. Then I usually resort to the geriatric depression scale, which is a little bit simpler. The PHQ-9 has a little bit more complicated scoring system, and anything over 14 warrants treatment for depression or further evaluation. Many times in the clinic it's very busy and we don't have time, so starting with the PHQ-2, and if that's positive, then extending to the PHQ-9 might be a good option. And in many practices now, medical staff such as MAs or nurses can do the PHQ-9 per protocol. The Cornell scale for depression and dementia is very similar to the geriatric depression scale, but it asks the caregiver. And many times in the clinic, I will give the caregiver the depression scale along with the patient just to compare the results. The Hamilton Depression Rating Scale is another one. All of them have a sensitivity and specificity of about 80 or higher. Question 2. Which is the strongest predictor of depression? Family history of depression, death of a spouse, past personal history of depression, loss of a job, or a new chronic disease. Death of a spouse is the biggest risk factor. Question 3. So our 75-year-old woman who lost her husband is getting treated for depression. Which one would you not choose as treatment for her depression? Lorazepam, St. John's wort, ECT, or paroxetine? you would not want to choose lorazepam. All the others are proven effective in depression. So first-line treatment is with this SSRI, serotonin selective reuptake inhibitor, or tricyclic antidepressant, or an MAOI inhibitor. They're all effective. However, SSRIs are first line because they have the fewest side effects. TCAs are quite anticholinergic, and MAOIs have a lot of side effects, including diet restrictions. In this Cochrane review, St. John's wort was as effective as standard antidepressants. Because supplements are not regulated in the US, we don't know exactly how much in each pill a patient gets, so that is not usually my first choice, but if patients really prefer to use over-the-counter supplements, then that is an option. This is a great chart that I encourage you to print out and use in your clinics to counsel patients with depression and come to a consensus and agreement which antidepressant to use. It addresses the side effects of antidepressants such as weight change, sleep disturbance, sexual issues, but also cost, how to stop or switch it if necessary, and other side effects or risk factors. So NRIs are other antidepressants that are second line after SSRIs. As NRIs have the benefit of having norepinephrine as an active ingredient, and therefore have more effect on motivation than the SSRIs. However, with SNRIs, we can lose some anti-anxiety effect. Some SNRIs in some patients may work for anxiety, but they can make it worse too. Trazodone is a quite weak antidepressant, but works great for insomnia to help patients sleep. And it can, in individual patients, work for behavioral problems in dementia, but well-done studies have not panned that out, but in an individual patients I have found some benefit. Other antidepressants also include mirtazapine. At low doses, mirtazapine is an antihistamine, and therefore it stimulates appetite and helps with sleep at night. At higher doses, it becomes more of an antidepressant and loses its appetite-stimulating and sleep-inducing effects. But overall, it is not a very strong antidepressant. In one study, there was no difference in weight gain between mirtazapine and sertraline in patients with depression. So if patients are losing weight because of depression, then maybe going with an SSRI is a better choice than with mirtazapine. Appetite stimulants in general are not recommended, and Megace has actually shown to increase mortality. Yes, patients do gain weight, but then they die sooner. We don't have this patient outcomes data on mirtazapine. I suspect that it might also increase mortality, but we just don't have the data. I suspect that the increased radical burden in patients who just cannot tolerate the excess caloric intake may be contributing to inflammation and therefore accelerate mortality. Hyponatremia is a very common side effect of all antidepressants except for Wellbutrin, and that may also even increase hospitalization for hyponatremia and cause delirium. So when a patient has some symptoms or side effects, check a sodium level and then maybe back off or change antidepressants to a different type. Bupropion or Wellbutrin, which does not cause hyponatremia usually, is oftentimes helpful in patients who also have addictive personalities, for example, gambling addiction or alcoholism or other addictive problems. Then these patients might do better with Wellbutrin or bupropion. It may worsen anxiety, so if patients have anxiety, this would not be an optimal drug to choose. If this medicine is used for smoking cessation, keep in mind to start the patient on 1 a day for 3 days, then increase it to twice a day, and encourage smoking cessation after 2 weeks, because it takes about that long for the blood level to increase in the brain and decrease the craving. Wellbutrin bupropion is also helpful in sexual side effects of other antidepressants. So the sexual side effects are usually due to a decrease in dopamine in relation to the other neurotransmitters in the brain, and bupropion can increase that dopamine level temporarily if given an hour before sexual intercourse. So does ginkgo biloba, and sildenafil, of course, can help with sexual symptoms as well. This is a study that looked at antipsychotic augmentation of antidepressants. Antipsychotics have a lot of side effects. They've been shown to increase mortality, increase falls, also the risk of weight gain and then diabetes development, high cholesterol, etc. So these are really only drugs to be used either by psychiatry or at the last resort if patients really don't respond to antidepressants, and several antidepressants have been tried. And aripiprazole seems to have the best data. Folate may be beneficial either as folic acid in 500 milligrams or methyl tetrahydrofolate, which is the more active ingredient, at 15 milligrams. Omega-3 fatty acids can also be effective for depression treatment. Acupuncture, inositol, or lithium have either no benefit or unclear benefits for depression alone. However, in individual patients it might work, so don't shy away from trying it, just stop it if it's not effective. Methylphenidate can help acutely in patients who are just very down and have no energy from the depression. It will give them energy short term and improve their depression and fatigue quicker than many antidepressants can take effect. How long would you treat a first episode of depression in an older person? 3 months, 6 months, a year, or 3 years? 1 year. So in younger persons, 6 months is usually sufficient, and then we oftentimes taper down on the antidepressant. In older adults, you want to treat at least a year. We do want to stop these medications after that year of treatment, or at least try to stop it, because of the increased risk of side effects, including falls. And depression in and of itself increases the risk of falls, but SSRIs in particular increase the risk of falls even more so. So these are some other medications that are contributing to falls based on the Beers criteria. And then, so all psychotropic medications fall into that category. But the start and stop criteria also include diuretics and vasodilators that contribute to falls that are not included in the Beers criteria. So this is the study showing depression and falls. Which drug can be stopped without tapering? Sertraline, paroxetine, citalopram, or fluoxetine? Fluoxetine, it has the longest half-life, so it's actually self-tapering. And the benefit of fluoxetine is also that when patients forget to take their medications, it can be given at any time, any day, even once a week. Sertraline is rather short-acting. Paroxetine is the shortest acting of all the SSRIs, so patients can undergo withdrawal if they miss a dose by just a few hours. So we have to have a patient who's really conscientious about taking it on time. I usually choose citalopram as my first go-to, and that's because it has the fewest amount of side effects, the fewest drug interactions, and is neither sedating nor stimulating. A lot of practitioners shy away from using citalopram because the QT prolonging effects of the drug at higher doses. This is a study from the VA that looked at QT prolongation in patients who were using high doses of citalopram and compared it to sertraline, and showed actually lower risk of mortality with citalopram, even though sertraline does not prolong the QT. So exercise is hugely effective for depression, and the more exercise, the better. The latest recommendations for cardiovascular disease, but also dementia prevention and cancer, is to exercise an hour a day. So the more intense the exercise, the longer, the better it is. This study looked at whether walking frequency or depression occurred first, but it seems like that the depression occurred first and predicted reduced walking frequency later on. So higher depressive symptoms are more likely to cause reduced walking, which then in turn can cause falls, because as we slow down our walking speed, we're more unstable and increase the risk of falls. Sleep apnea is a big risk factor as we get older. 68% of older adults have sleep apnea, and we don't even have to be obese to have it as we get older, because the tissues in the back of the throat become so floppy due to decreased elasticity of all of our tissues, so that we're at higher risk of developing sleep apnea as we get older. And CPAP has been shown to help with lots of symptoms and problems, including depression. This study showed no benefit on depressive symptoms for patients who don't have depression, but big beneficial effects in patients who have depression. So if you have a patient with depression and they're maybe overweight or at risk of sleep apnea, ask them about it and ask them to get evaluated. Electroconvulsive therapy has been shown to be effective for depression in lots of studies, and in the 60s got a bad rap with the then subsequent movie of One Flew Over the Cuckoo's Nest. So a lot of patients or their families are resistant to ECT, but in my experience it is very effective for patients with severe depression who have not improved with antidepressant treatment. So labs to obtain when evaluating a patient for depression include glucose levels. If patients are hypoglycemic, that puts them at higher risk of depression. Vitamin B12 level. I don't routinely order folate levels because our food supply is now supplemented with folic acid, so that the majority of my patients, or I have rarely seen a patient deficient in folate. But other tests to do is thyroid function test, and in older adults you want to replace the thyroid hormone if the TSH is above 6, and you want to keep the TSH with treatment of levothyroxine between 4 and 6 in older adults to reduce the risk of atrial fibrillation, skin thinning, muscle atrophy, and osteoporosis. For anxiety, antidepressants, particularly SSRIs, are effective. Question 6. Regarding assessment tools used in the evaluation of memory loss, which of the following statements is most accurate? The Mini-Mental Status Exam evaluates executive function and visual spatial skills. Formal neuropsych testing offers no benefit over the MMSE for detecting dementia. The use of a screening tool for depression is not helpful in the evaluation of memory loss. Clock drawing evaluates executive function and visual spatial skills. And the Blessed Information Memory Concentration Test can differentiate between Alzheimer's dementia and vascular dementia. The correct answer is clock drawing evaluates executive function and visual spatial skills. So I asked the patient to draw a large circle, then put all the numbers into the circle and let the hands show 10 after 11. And if you don't say it exactly like that, then oftentimes patients will draw this clock in the left lower quadrant that only has the digital numbers in it. So you do want to say, let the hands show 10 after 11. And the reason we use 10 after 11, because mildly cognitively impaired patients who cannot abstract anymore will place the hands at 10 and at 11 because that's what they hear. But 10 after 11, the larger hand has to be placed at 2 o'clock, and therefore if you said 10 till 11, you would miss that in mildly cognitively impaired patients. So treatment of depression in dementia can be very tricky. It oftentimes is not effective. First-line treatment is still an SSRI, a serotonin selective reuptake inhibitor. But in many studies, there have been no benefits of treatment with antidepressants. So the way I approach it is I treat my patients if I identify depression and they have dementia, but then I monitor them and see if it is beneficial. And after a couple of months, if there's no benefit, then I will taper them off and see if they're getting worse. And if they are, then I will restart it and see if they're getting better. So in conclusion, depression presents very differently in the elderly. An SSRI is the first line treatment, and treat older adults at least 1 year for depression. Thank you.